Hello, everyone, and welcome to our event, Yemen Crisis, Impact of War and COVID-19 on Maternal Health. My name is Dr. Wendy Lai, and I'm the president of the board of directors at Doctors Without Borders, Médecins Sans Frontières here in Canada. I'm joined today by Dr. Rupen Gill, MSF Field OB-GYN and Women's Health Advisor, to talk more about the crisis in Yemen and how war and COVID-19 are impacting maternal health. Welcome, Rupen. MSF is an international Nobel Prize-winning medical humanitarian organization. We provide emergency medical care to people affected by disaster, conflict, epidemics, and those excluded from healthcare. In Yemen, at the Doctors Without Borders, Médecins Sans Frontières supported hospital called ABS Rural Hospital, our team runs a large maternity project, which includes emergency obstetrical care, pediatric health services, and a newly built neonatal wing. The need for maternal and child health care across the country is high and increases every year. This hospital is the only available health facility providing specialized medical services for more than 1.2 million people living in the area. Now, as COVID-19 spreads across Yemen, the needs of people caught in one of the world's worst humanitarian crises are growing. Dr. Gill, let me do a more thorough introduction. Dr. Gill completed her medical school training at the University of Toronto, her residency at the University of Ottawa, and fellowship in family planning at the University of British Columbia. She received her Master's of Public Health from Harvard T.H. Chan School of Public Health. She's published in a number of peer-reviewed journals, worked as a medical officer with the WHO Department of Sexual and Reproductive Health Research, and currently is a consultant for the WHO. Dr. Gill also works as an emergency obstetrician for MSF, with field missions in Nigeria and Yemen, and most recently joined MSF as a Women's Health Advisor. She's a recipient of a number of grants to support her work that intersects family planning, digital health, and humanitarian and development contexts, with a project currently in Venezuela. Rupen, thanks again for joining us today.
Thank you.
And maybe we'll start with having you tell us a little bit about what inspired you to work with MSF, and about your field experience in Yemen.
Thank you so much, Wendy, and thank you for everyone that's here for joining us today. It's my pleasure to share about my experience in Yemen. Wendy, I've known for a very long time that I wanted to have a career that involved me working with communities globally. When I was younger, I didn't actually really know how that was going to be realized. I've always really had this sort of deep desire to really understand the structural issues that are at play in our world, in the current world that we live in, and that why do we even have the term fragile state? Why does that even exist? Or that there's some places where the healthcare systems are just not even fathomable in our own context. I've been inspired by organizations like Médecins Sans Frontières because they're very value and mission driven, and they're a type of organization I wanted to work with. But it was a little bit unclear to me in the early days when I was going through my training, how does an obstetrician gynecologist fit in this work? And actually, my journey in the humanitarian sector started back in 2014 when I was doing my master's at Harvard. And it was actually at the time when Ebola had just hit West Africa quite hard. And so in all our classes, we were talking about it. And again, it made sense to me that emergency doctors or the surgeons and anesthesiologists, all my classmates that were there, that it made sense for them to be a part of this humanitarian work. But we weren't really talking as much about sexual and reproductive health, and felt that I didn't really have anyone that I could relate to. Now, fast forward, when I started my fellowship in family planning, which involves complex contraception as well as advanced abortion care, one of my colleagues and dear friends, who also works for MSF, she was working full time, also had completed the fellowship, and she said, you should consider working for MSF. Their values are very aligned with yours, and that's what inspired me to work for them. And I think really, and I want to emphasize this, is that today we're talking about maternal and newborn care. But what I really value about what MSF does is that they also work on other areas of sexual and reproductive health. So whether that's to prevent unsafe abortion, ensuring access to contraception, and providing care for victims of sexual violence. And then I've done 2 missions, as you mentioned in my bio. Nigeria was my first mission. It was absolutely amazing. And then Yemen. And in Yemen, I was an expat obstetrician gynecologist, and I worked with an amazing team of national midwives and nurses. And my main role there was quite clinical in terms of providing emergency obstetrical care with regards to many complex cases that we would hardly see in our Canadian context, in a very, very busy maternal health hospital, servicing, as you mentioned, 1.2 million people.
And yet, Yemen is currently an issue and a major humanitarian crisis because of the conflict going on there. So, I think a lot of people would have a question, to say, if what's going on there is mostly conflict related in terms of healthcare, sure, it makes sense to be doing kind of trauma related surgeries. But what does that have to do with women's healthcare, and what are the needs there in Yemen?
So in terms of the needs, so maternal mortality ratio is quite high. It's one of the highest in the world, and we know that in terms of maternal mortality and morbidity, places like Yemen and some of the other fragile states, if we don't address the care there, then we're really not going to be able to move the needle on maternal mortality. Some of the key issues here, it's correct in terms of, it's a conflict zone, so you think that there's a huge need for trauma surgery. But in a humanitarian context, there's such a vast majority of women and children that are impacted. And particularly, it's the collapse of the country's public health system. So in a setting where you have a collapse, that means that you're not going to have access to high quality, safe maternal health care or care for children. And particularly in Yemen, we know that because of the collapse of the country's public health system, we can't. That means that the needs of Yemen's 28 million people are not being met. Also, private care facilities in Yemen are unaffordable for many women. And that's why MSF, in terms of us providing free services, is essential. There's issues around security, and particularly in a setting like Yemen, where it is a little bit more conservative. It can be quite dangerous for women, pregnant women particularly, to try to reach a hospital. And then on top of that, with airstrikes and checkpoints, it can have a lot of dire implications for the women. And then the other piece of it is that there can be these unanticipated delays in reaching the hospital. So road closures, checkpoints, and torrential rains, the climate issue as well, which is impacting Yemen.
So I'm going to remind our listeners that we are taking questions. If you have a question for Dr. Ruben Gill, Women's Health Advisor for MSF, Médecins Sans Frontières, also called Doctors Without Borders, please send them along to us. And in the meantime, she and I will continue our conversation about the maternal and child healthcare needs in Yemen. I want to ask you, Rupan, a little bit about the facilities that you were working in Yemen, and maybe contrast them to another context where you spent some time, which is Nigeria. What were they like, and how do they compare to a Canadian labor and delivery ward?
Great question. There's so many similarities in terms of the Nigeria and Yemen sort of context. One of the key things I want to highlight is that a lot of the work that I do is with midwives. So, for example, in Yemen and in Nigeria, you would have about 40 to 50 midwives per one gynecologist. And in both of these contexts, the midwives are the ones that are really sort of doing the vast majority of what we would say low risk care. And as an emergency obstetrician, I'm mostly responsible for addressing the complex care. The other things in terms of the similarities, I would say, with Nigeria and Yemen is that you have so many, and actually in Nigeria, our maternal health project there is one of the most, actually has one of the most complex patients in a lot of our MSF projects. So for example, the numbers of preeclampsia, which is high blood pressure in pregnancy, obstructed labors, uterine ruptures, these things that you just wouldn't hardly see in our Canadian context, come through the door in Nigeria and Yemen. You'll have dozens of patients like that. And in Nigeria, one of the complexities is that we have a lot of young women that are suffering from cardiac disease in pregnancy, which is something that you wouldn't even really consider as much of an issue in a Canadian context. The other issues are around, the one-on-one nature of care. So you will have midwives that are taking care of multiple patients at once, whereas in Canada we have one nurse to one patient. And then even in terms of just the infrastructure, as you'll see through some of the videos that are coming through here, is that because of the volume of care and the volume of patients that come through, you have beds that are sort of side by side, that are not necessarily the same in Canada, where you'll have your own private room, private suite, etc. Just to give a little bit of a contrast as well, which is similar in both Nigeria and Yemen, because they're both very, very busy maternal health hospitals. I would come to the hospital in the morning and, ask the midwives, how was your night? And I would go in at night to deal with emergencies, but they're still, continuing to do all the low risk deliveries. And in one night, so a 12-hour shift, they would do about 30 to 40 deliveries. Now, just a contrast to a busy Canadian labor and delivery ward, you may do, like, a busy night would be, 8, 10 deliveries. So there's a lot. I mean, there's a lot more in terms of the contrasts, both. But
that certainly stands out. That certainly stands out for me as well. I've spent a fair amount of time in Haiti, where we were doing an emergency obstetrics project, and exactly as you say, lots and lots of severe preeclampsia, so pregnancy-induced hypertension, and many complications following from that in ways that I thought about before here in Canada, but not really seen, and certainly not appreciated, as a clinician, not appreciated how important and how much morbidity and mortality follows on from these illnesses, that they seem so conceptual to us here in Canada, but in fact, of course, they're very, very real illnesses. And then again, as you say, in Haiti, we also certainly had this problem of just a lot of volume of patients needing care, needing attention, and a relatively kind of limited resources in terms of skilled personnel, and so kind of being able, having to juggle both the severity of their illness and then our capacity to look after them was certainly a challenge. And this follows nicely into one of the questions that we received from someone who's listening. It's from, I don't know if it's pronounced Raya or Raya, but Raya is wondering, having obtained your training here in North America, how difficult was it for you to adapt to the different needs and the unique cases that you don't normally see here in Canada? How did you prepare for that?
Well, first and foremost, I have to credit my residency program and my training. So I do think that being a Canadian obstetrician gynecologist and a Canadian trained OBGYN, we're very, very fortunate, so that you do get a lot of this theoretical training, and you do see patients still with not as much actually, but the preeclampsias, etc. And then, of course, with my surgical training, I felt quite confident that I would be able to address the surgical cases that would happen. So I do have to commend the fact that I felt quite prepared, because I'm lucky to be trained in this Canadian context. And particularly, I do want to give a shout out to University of Ottawa, because that's where I did my residency training. And then I think that what helps, I mean, with MSF, when you're going into the field, you're not going without being prepared. So I think that's just something really important to highlight, is that it's a whole team effort. So I was briefed by other gynecologists that have been in the field. I was briefed when I got to the field by the folks that are there. And I should highlight that MSF was not my first global health experience. I had experience working in multiple African countries before, throughout my residency training, through medical school. So I didn't feel like it was a major shock. And I think that's also an important factor to keep in mind, that working for MSF is something that you do when you do feel a bit more competent and ready as a clinician to work there. So you have skills to be able to provide.
Yes, absolutely. And in fact, when I first joined MSF, about a year out of my residency training. In fact, let me clarify: I'm not a gynecologist. I'm an emergency physician. But I was a year out of my training, and I felt really fresh. I think I would have done better if I'd had kind of more clinical experience under my belt, and so that shouldn't be underestimated. I want to welcome those of you who are joining us right now. We're speaking today about the crisis in Yemen and how war and COVID-19 are impacting access to maternal health. My name is Dr. Wendy Lai. I'm the president of the board of directors of MSF Canada. As I said, I'm an emergency physician. I work here in Toronto, and I've been part of MSF since 2006, having worked in contexts like Democratic Republic of Congo, Haiti, and the Central African Republic. I'm joined today by Dr. Rupin Gill, who's worked with MSF in Nigeria and Yemen as an emergency obstetrician, and she's currently a women's health advisor. There is a question here from Manpreet asking for perhaps a story about one of the most inspiring patients, or maybe a difficult patient that you've treated. Do you have a story that maybe can illustrate, Rupin, some of the barriers that are facing patients in Yemen?
Wow, yeah. So I have many stories that I can share, but I would like to share one that was from my most recent experience in Yemen that was quite inspiring, and it has some sad components to it, but also a lot of positive components. So we'll call her Radia. So this patient, she arrived to our ABS hospital, thinking that she was pregnant with twins. And she had traveled to the hospital. And like I'd mentioned earlier, patients like Radia or women like Radia, they're having to travel for days. They may have to go through treacherous terrain. There's airstrikes. You have checkpoints that you need to pass to get to a healthcare facility. And also, particularly with ABS Hospital, we were only 25 kilometers from an active frontline. And so that's something else that's really important to know about a context like Yemen, where you have these ever-changing front lines that can actually impact access to care and to get to the main roads. So Radia, she had little to no antenatal care, and she also had undiagnosed high blood pressure in pregnancy, preeclampsia. And after the midwives actually delivered her first twin, and I will say that I remember this case so well. I remember the patient. I remember all the midwives that were involved in the care. I remember the expat midwife, who's a fellow Canadian, who was with me so clearly, and it's just amazing. So she delivered her first twin, and then what ends up happening is Radia starts to seize. And so the diagnosis of that is eclampsia. So it's a condition in pregnancy, super rare in the Canadian context. So the midwives, again, swiftly and urgently managed her seizure, called for me. I delivered the second twin urgently by assisting the delivery with a vacuum. And as the team was resuscitating the twins, which again, it was midwives resuscitating the twins, I examined the patient. I say, hold on, actually, she's pregnant with triplets. So I break the water, and it was crazy. So I just want to highlight here, in Canada, we do not deliver triplets vaginally. So I break her water, and I notice that she's having a massive placental abruption. So as I'm going through the story, you can see there were multiple complications this one patient faced in this one scenario. And placental abruption is basically when the placenta is separating from the uterus and has dire consequences for the mother as well as for the baby. So I deliver the third baby feet first, so breech. And now the positive part of this story is that, I mean, it was super inspiring, not only because the mother did fine. And this is, to credit to MSF's high quality care that we provide in these types of facilities, all three babies survived. And it was at the time when ABS Hospital had opened their new neonatal wing. And I think what's the most moving for me in these circumstances, the patients, but also the team. So the midwives, the nurses that were working with me to make this whole thing work and to really help this patient, I will never forget that. So that's one really inspiring story for me. However, I do want to highlight that I've had multiple cases that have been very difficult. I've had multiple maternal mortalities, and particularly in Yemen is when I actually did my first perimortem cesarean section, which basically it's sad, but I will share it because I think it's really important to highlight this, is that there was a patient who came and she had a cardiac arrest. And so when a pregnant person has a cardiac arrest, you need to do a cesarean section within 5 minutes of her arresting. And so I had to do the cesarean section in the labor ward while the team was sort of supporting the patient and resuscitating, etc. So those are kind of like the powerful, intense adrenaline rushed moments that you experience
Yeah.
in contexts like Yemen.
Yeah. That's an amazing story about the triplets and the abruption, and I'm really glad to hear that that has a happy ending. And now is probably a good time to note it is the International Year of the Nurse and the Midwife, and nurses and midwives are absolutely and not only an important part of the care, but in for many patients, especially the relatively straightforward ones, they are the ones who are delivering the bulk of the care, and really taking on a lot of responsibility, and probably more than would occur in a typical healthcare facility here in Canada. So, we're an organization called Doctors Without Borders, Médecins Sans Frontières, but in fact, it's not just doctors, and it's a relative minority of doctors, and many other skilled health professionals are crucial to delivering the care that we do. I want to move on a little bit because we promised we would talk about COVID-19 as well. Hafsa asks, how has COVID-19 changed the labor and delivery wards? And actually, I'll expand that question a bit more as well and say, like, how has that changed hospital and kind of healthcare in general in Yemen?
So it's really interesting because I can really, shed light on that from an anecdotal standpoint, but then also, in terms of some evidence that we have that, with the decrease in provision of essential sexual and reproductive health, there are implications in terms of maternal health and actually sexual and reproductive health in general. In Yemen, I will say, like, I don't have necessarily hard evidence or the data to say, I don't have the numbers per se. But what we do know, and what I know from my time there, because I was there for 6 months, is that COVID-19 definitely did have implications in terms of women and children's health. So, for example, pre-COVID, before there was any cases in Yemen, and post-COVID, after there were cases, we noted that there was a lot more maternal deaths. And this could be due to multiple reasons, but what we do know is that there started to become this fear for women to come to hospitals because of COVID-19. And then on top of that, because of the fact, like, the ABS hospital is a tertiary hospital, so we're providing, emergency care, surgery, etc. But we also have a huge catchment of health centers that are surrounding, where women will go first and then be kind of referred to ABS. So surrounding health centers were closing. And then on top of that, we as MSF also had to stop our community outreach work. And our community outreach work is so essential and important to what we do. So that's meant that our patients, the women, were presenting to ABS at a much later stage than they normally would. And I think in a context like Yemen, so with COVID-19, we did have to divert some of our resources with regards to our maternal health and what we were providing in maternity. That did not get implicated. With regards to sort of outpatient care, for example, antenatal care, those things had to be readjusted. So you couldn't have the antenatal care open all the time. And this was sort of the global sort of way of doing things, was to try to minimize the number of visits people would need to have in a hospital. In a context like Yemen, where you have an already sort of fragile healthcare system, and then on top of that, there's economic factors. And at the time when COVID was hitting Yemen, there were also these torrential floods and sort of natural disaster type situations as well. So you can see that there's a huge implication of COVID. There's climate change issues, and then on top of that, conflict. So you put all those things together, women and children are the ones that are bearing the brunt of that.
Yeah. And that's really just a demonstration of the vulnerability, and how women and children and the most vulnerable populations are the ones directly and severely affected by multiple converging crises at the same time, right? The conflict and the epidemic and, as you say, climate change. I want to welcome those of you who are joining us right now. I'm in conversation with Dr. Rupen Gill, and we're speaking about the crisis in Yemen and how war and COVID-19 are impacting access to maternal health. My name is Dr. Wendy Lai. I'm the president of the board of directors of MSF Canada, and I'm an emergency physician here in Toronto. Dr. Rupen Gill, who I'm speaking with, has worked with MSF in Nigeria and Yemen as an emergency obstetrician and has recently joined MSF as women's health advisor. And I want to go from Rupen, because we were talking about the antenatal care that we were performing kind of by outreach. And Mary has a question here. Let me see. Mary says, can you speak to the viability of community-based care for women in the midst of childbearing, since the public health system has collapsed, and given that many women's childbearing experience would likely not warrant hospital care, are there families involved in childbearing experiences at home and in the community? Who is responsible for postnatal care, and what does it involve? There's a lot in there, but I'll let you tackle whatever pieces of that
Yes,
you want
I
to.
love this question because
Of your research, I think.
yes,
Super.
because of my research, but also with my new role as a women's health advisor with MSF. Well, first and foremost, I think it's interesting because MSF, I think a lot of people have in their mind that it's like doctors that are going to the field and we're doing this like emergency surgical care, but there's so much more to MSF that's happening, sort of that's behind the scenes. And the community outreach piece is a big one. And so there's a lot that happens already by baseline in terms of our mobile clinics that are going out and seeing patients that are in IDPs or just in the different villages, and that's happening in Yemen. But something that has come up with COVID-19, and this is something that many organizations are discussing and talking about, and because of sort of my research work as well, is the value in terms of promoting community-based models of care as well as self-care models of care. So, for example, empowering women and girls to be able to care for themselves. So, for example, for contraception, we have new innovative technologies where women can actually self-inject the contraceptives themselves. So there's an amazing new contraceptive method, Cyana Press, that in some of our fields we're starting to implement. So that this whole idea around self-management and community-based models is definitely something that we're talking about and thinking about. But we already do it. So that's just one thing I want to highlight is that MSF already does it through its amazing community outreach-based models of work. And then throughout different projects, it depends on which project we're talking about, there'll be different types of partnerships. So for example, with one of our MSF projects in the Philippines, we have a really nice partnership with a grassroots feminist organization that basically provides comprehensive sexual and reproductive health. But MSF and this grassroots organization, LICAN, work together very closely. So I just want to highlight that there is a lot of this type of stuff that's happening and that we do try to support it. And as time is going on and especially with COVID-19, we've realized that we need to do more. So whether that's using hotlines, telemedicine, digital health, all these kinds of types of opportunities are starting to spring up.
Thanks, Ruben. There's a question here as well from Madiha, who asked about, so we were talking about preeclampsia. So she says, there are many pregnant women with conditions such as high blood pressure in Nigeria and Yemen, and I'll add Haiti. And she's curious about why. Would you be able to say why this is the case? For example, is it due to lack of healthcare services and the living situation overall? And certainly because we saw so much of this in Haiti, this is a question I asked myself frequently. Not being a gynecologist, I did not have the background to answer it, but it certainly seemed like many more than certainly than I've seen here in Canada, and I heard all kinds of theories as to why, about whether it was related to poor nutrition, rates of background stress, stunting in the mothers, previous traumas, genetics. I mean, I feel like I've heard all of the theories, but none of them ever came out as sort of the top one. So there's a question here about whether you have a sense of why that is.
Wendy, I mean, you kind of hit it on the nail. I think there's so many of these. There's it's not just one reason why. I think it's all of those things. There's malnutrition and issues around nutrition. There's the fact that despite our best efforts with encouraging antenatal care, in a lot of these places, women are still not going to the number of recommended ANC visits as per WHO. So there's one thing in terms of having the recommendations and even having those services in place in some way. It's also the next piece is to really understand why are women not going? What are the barriers or even the facilitators? So I would say it's related to the ANC. It's related to malnutrition. It's related to the fact that the gestation is quite high. So a lot of, like in northern Nigeria and Yemen, every patient would have 5, 6, or 7 or 8 pregnancies. I meant to mention that earlier as well, is that it's very different to the Canadian context where you may have 1 or 2 pregnancies per patient per woman. So it's quite complex, and I will share just from a personal note, and especially now that I'm in this new role, and with my experience both with MSF and then outside of it, is that we, regardless of the context, so if it's Yemen, if it's Nigeria, if it's Afghanistan, Pakistan, I'm always thinking to myself, like, what is it that we're not doing enough that is still having a lot of these, like this high burden of preeclampsia and eclampsia and all these types of cases that are even birth asphyxia, which we haven't really gone into, but there's a high number of neonatal mortality and death that we manage and deal with, which is very challenging and difficult because we wouldn't see the number of types of neonatal death in Canada like we do in these settings. But why? And so one of the things that I've been really reflecting on is that what we need to do is better understand our beneficiaries, the women themselves. What is it that is preventing them from accessing the services that they need to access? What are the issues that they're facing, whether that's pregnancy, but then there's a whole piece after pregnancy. So the postpartum piece, what can we do better in terms of ensuring that women get the appropriate follow-up in the same way that they get follow-up in Canada?
Yeah, and certainly from a public health point of view, I mean, finding answers to those questions about, why is this happening and how is it that we can, where's the bang for the buck in terms of how do we prevent some of these illnesses from arising in the first place, right? And so it's one thing to be treating women as they're coming in with their complications already, but obviously the goal would be to be able to provide something to be able to prevent it. I'm going to go to Clea. I'm going to go to Clea, who would like to have a sense from Yemen about what the situation would be like for pregnant women and other Yemenis if MSF wasn't there. What would be their experience and what would they be going through?
It's interesting because, well, first and foremost, MSF is just one actor in these settings. So we provide care, but also UNFPA. So in Abbs Hospital, there was also UNFPA that's there. You still have, I mean, we work very closely, and we should highlight this, is that we work closely with Ministry of Health. So in Abbs, there's parts of services that were Ministry of Health focus, and then that were supported by MSF. There are some settings in which if MSF was not there, that the women would suffer, because we do provide free healthcare service and it's high quality. We have the supplies. I mean, as an OBGYN going to an MSF supported project, I feel very comfortable because I know that I have all the equipment that I'll need when I'm providing emergency care in terms of emergency cesarean section, if I need to do a hysterectomy. So we have the supplies, we have, everything is sort of set up. So it is, if that's gone, then it does have implications for patients like Yemen. I do want to highlight, actually, because we do have a sad circumstance in which it's not Yemen, but it's another country in the region, which is Afghanistan, where one of our MSF hospitals, now you have an ongoing conflict and COVID-19, And then we had an attack in one of our maternity hospitals in Western Kabul. And that killed 24 people, staff, mothers, children. And so all maternal health care seized. And this is for a patient population or a population that we've been servicing for a number of years. So the implications of this are tremendous. But on the flip side, MSF is trying to think of other ways that we can still support the population, and that involves working with national midwives, midwife association, and other sort of actors. So it's complicated. It is complicated, but it is important to note that we're not the only actors working in these humanitarian settings. Like we have UNFPA, you have WHO, you have other folks as well.
Yeah.
IRC.
We're going to take a couple of more questions, and then we'll have to wrap it up. But I do want to get to this one from Raya, who asks how workers cope with the trauma experienced and the added stresses in these areas. I mean, you just mentioned Afghanistan, which was a particularly traumatic experience, right, where the hospital was attacked, and I think many of our staff, both our international staff and our locally hired staff, do see a lot of things happen, again, that are very different than what clinical practice is here in Canada.
Mm-hmm. This is one thing that I really credit MSF for, is that we have a very sort of strong psychosocial unit, and that is really emphasized. So before you leave on mission and you go to the field, and then afterwards, there's always this consistent check-in to make sure you're okay. In my case, for example, I was meant to leave Yemen in March 16th. March 16th was when I was leaving and the country shut down. And then I didn't actually leave until June 16th. And I have to say, during that time period, so the psychosocial unit would just check in with me. They would call me, they would email me, just to make sure that I was doing okay. And then they have all these support services, even extended beyond the psychosocial unit. So if you needed to speak to somebody, see a therapist, etc., those services are supported. So it's really important, and I think it's really good that MSF does that, because you do see many things. And you may not necessarily feel the post-traumatic stress or right away after you come back from the field. But like my pool manager told me, and also the psychosocial folks, is that you may feel those implications, or those you'll feel it residually later on. So I will say, and I think it's so important, and we have so many folks that are doing a lot of work on the mental health side, especially with COVID-19 when that started as well, that there is a whole part of MSF that's really focused on that, and that's really important, I think, that our viewers know about.
Yeah, very important component, absolutely. Mm-hmm. And last question, Hafsa asks, how many years of clinical experience would you recommend before applying to MSF? And maybe I'll throw in with that whether there were particular skills or courses that you focused on.
I mean, it's interesting. I did my residency, and then 2 years my fellowship, and then that 2 years my fellowship, I spent a lot of time doing clinical obstetric care, and I felt that was sufficient enough to get me to feel comfortable going on a first field mission. So I'm still quite early in my career in terms of with MSF and as a clinician. But I would say that working for MSF is beyond just the clinical training. I think in general for global health work, my advice would be, which is what I did when I started off, was just really try to understand the issues. So read a lot, be familiar, before you're considering to do this work in these kinds of settings, have an understanding of first and foremost why these types of inequities exist, and why, like I said at the very beginning, why do we even have a term like fragile state? That shouldn't even exist in our lingo, or our terminology. So that's sort of my main advice on that.
Thanks. I think that's a really great note to end on. Indeed, global health is much more than just a technical set of skills. The technical piece is important, but even more than that is essentially an ability to adapt to a variety of different kinds of challenges, and understand kind of what are the reasons for there, and what's the basis for the humanitarian action that we're undertaking. Mm-hmm. So I want to thank Dr. Rupen Gill for joining me today, and I want to thank all of you for joining us for our event, Yemen Crisis, Impact of War and COVID-19 on Maternal Health. If you would like more information about our work in Yemen, or how to get involved with MSF, or how to make a donation, please visit our website at www.doctorswithoutborders.ca. That's all one word, Doctors Without Borders. If you're interested in working with MSF in the field, please join us for an information session next week, which will be in French. We will continue to post more information on this event in the chat, and I think it'll be available on our website as well. Ruben, I really appreciated speaking with you. It gives us a really good sense of what's going on in Yemen, and indeed the many things going on, and as you said, multiple crises that are occurring concurrently and that make a humanitarian crisis all the more complex. Thanks a lot. Have a
Thank you
good
so
afternoon.
much. You too.